discretion of an auctioneer. Chest pneumothorax going once. Chest pneumothorax going twice. So an open pneumothorax, that's when you have an open hole into the chest and it's a sucking chest wound and it collapses the lung. The treatment for it is we put the occlusive dressing on it and leave one side of it up, and that side works the flutter valve. So the exhale will blow the air out. When they inhale, it'll shut it so that the air doesn't come back in. Make sense? If you seal all four sides, you'll cause a tension pneumothorax and it will kill your patient. So do not seal all four sides. Any questions? That is a picture of what it looks like if you seal all four sides. It'll come in, it'll crush the lung, which will then crush the vena cava, which will then crush the heart, and soon your patient will be dead. Any questions about open pneumothorax and tension pneumothorax? You need to know the signs and symptoms of each. Signs and symptoms of a tension pneumothorax. So think about it. It's crushing your lung, either the right or the left lung, whichever one it is. And that's going to crush your heart and your vena cava. So what's going to happen? You're going to be in respiratory distress because you can't breathe. It's only got one lung. The blood, when it starts crushing the vena cava, is going to push the blood back up into the jugular veins. The jugular veins will be distended. In late signs will be tracheal deviation. I've seen a lot of tension pneumothorax. I personally have never seen tracheal deviation. But the trachea will pull towards the one good lung because it will be sucking air so hard it'll actually deviate the trachea. You'll have tachycardia. Since the heart's being crushed, you'll have low blood pressure. They'll be turning blue, cyanosis, and you won't have one lung sounds on one side of the chest. It'll be absent. Any questions? All right, here's an example with tension pneumothorax.
Zaprezentujemy, jak pracują zdrowe płuca, cały proces wentylacji i oddychania. Tkanka zdrowa, nieuszkodzona. Jak to wygląda w sytuacji, kiedy mamy szczelnie zamkniętą klatkę piersiową i płuca pracują w klatce piersiowej. Okay. Drugi preparat został uszkodzony. Najpierw zaprezentujemy ciśnieniowy uraz po eksplozji. Tkanka jest uszkodzona i powietrze ucieka. Wiemy, jak to działa w sytuacji uszkodzenia.
So the air gets cleanses at the pleural space, then crushes the lung.
Po nakłuciu. Opatrzenie.
Hang a hole and see how you decompress it. Let's all the air out. Make sense? All right. So the tension pneumothorax develops after you've sealed an open chest wound. Make sure you unseal it to allow one corner to let air escape. If there is not an open pneumothorax, you have a tension pneumothorax, you need to throw that person into an ambulance and get them to someone that can decompress the chest as soon as possible. That'll either be a paramedic or an ER doctor. But someone's got to stick a 14 gauge needle into their chest and decompress it. This is what happens when they do that. This is actually shot from a doctor, I believe, in Georgia, on a live patient. He took a thoracoscope in with tension pneumothorax to show what chest decompression looks like from inside. Pretty cool stuff. This is Georgia. Not Georgia, the United States, but Georgia, the country. Actually, he's in Ukraine. lunch should be all the way at the top of the pleural wall there. Stuck a 14 gauge needle and then pull the needle out in the catheter. Then now all the air pressures on the chest is going to release the catheter. And you're going to see the lung reinflate. That's what it should look like. Questions? What's that? No, you got to go to a paramedic or doctor and just show you what it looks like, what needs to be done. So here's one with the military where the guy's actually got to be decompressed twice.
Oh, they're just most of my time in the Army.
Oh, but what's the Stephen named after?
Stephen is from Navy Federal Credit Union. They've been helping with my finances since I enlisted. You want another Stephen, Stephen?
Keep him going.
Okay.
Maybe someday I could get a sandwich named after me. No.
Navy Federal Credit Union. Our members are the mission.
Sweet always comes first. This sweep reveals no other injuries, but he's in critical condition. The gunshot wound has trapped air in his chest, crushing his lungs. It's up to the rookie to save him. Barry readies a chest dart, a needle inserted into the torso to relieve pressure. If Barry misses the mark, he might hit an artery, a fatal mistake. But he's still struggling to breathe. Dude, think they're on camera. Sit back. The soldier is suffocating. And that readies a second dart. The soldier can finally breathe.
If in debt, they haven't done that, it will crush the entire heart and lung. All right, so hemothorax. That was way too graphic, the hemothorax. The guy stabbed in the chest in the ER. Anyway, so hemothorax, same with the pneumothorax, it's blood instead of air. You do not get tension hemothorax though, but it does decrease their ability to breathe. You also lose a lot of blood into the chest cavity. So they become hypotensive. And if you get air and blood inside there, then it's called a hemopneumothorax. And this one sounds like a coffee percolator. Any questions on pneumothorax, open pneumothorax, tension pneumothorax, hemothorax, and hemopneumothoraxes? Yes.
You were the person needed to review the today line. Are you BBMing them? Because when you do like.
Not always.
add to the problem, would that
That's
add
one of
to
the problems with BBM, yeah, but they're not breathing adequately, you have to be.
You wouldn't do non-repeaters still with.
No, they're not breathing adequately, the non-breather is not gonna happen like that. So, you gotta be able. Yes, if you BBM the positive pressure, it's gonna make the tension pneumothorax go down much quicker. Any other questions? All right. There's an example of a hemothorax and a hemopneumothorax. Looks like we got some videos of each one of these. Maybe. Not that one.
Un espacio costal abajo para hacer un túnel y nuestro corte es
What we're doing here is we're putting in a chest tube. It's how you get rid of or how you fix a pneumothorax or a hemothorax. Only the surgeons can do this. Paramedics can't do this. What they do is they cut a hole in the side of your chest, they stick their finger in, and then they stick a tube in, and they run it into a water seal.
un espacio costal abajo. ¿Solo? Ninguno. Perfecto. Hay que finalizar. Aquí entré, meto mi dedo hacia el interior y ya siento la pleura y esto.
That's how you fix it. Now, if we're ever in apocalyptic times, you guys know how to fix it if ever get shot.
To stand all the way down to the shoulder blade. The shoulder blade all the way down. You got the strip spreader. Scissors. Let's open the. You need to make it tight. Go in between the ribs with the knife. Yeah, work on the thread. Get 4 eyes right. Let's go. How much? On the bottom left. Where is it? Over there, right there. Grab those. That big hill after that. Where you have to pull that tube up. Trying to pull the tube out, yeah. You're right. I know, but he doesn't have space. That's the wrong way. Go ahead. Okay, so I'm gonna open it up. It's bleeding on the right side. Go ahead. So you got the big clamp? You got the big clamp?
Right there.
Take it on across. You're gonna have to go right on across up there. Open that chest up more. Open up the chest more up there. Take it on. Take your scissors on up there. It's a big plan for the air. We need blood. Yeah.
And a Foley. 2 minutes before. We're gonna Foley catheter. With a syringe.
Give me a light. You're gonna need, you may need to cross clamp the aorta. So open it all the way up. Maybe all the way up. Come on. Grant, open the wide.
Right now, I'm at the right there.
No, that's new, but look at your heart. Hold, expose your heart.
Part of the chest.
Deliver the heart. Deliver the heart. Let's see. We've got one out. It's like. He's got fluid, whatever we got. Oh, yeah. The sensitive, yeah, that mammary artery is bleeding. Here. Plant that off. But, make sure you got aorta.
I feel a pulse. You've got a pulse right now.
You got a good cardiac.
OG too down.
Yeah, just make sure, yeah, put an OG down.
I can't grab my hand there.
That's what they can do if you can get them in there in time. Here's another good deal there. This is the one that. So watch out, blood comes out of his chest. You can see the thorax.
41-year-old son of Atlanta was robbed from his paycheck. He was shot in the back and is bleeding heavily. He's sure you get very good at dealing with it. You deal with it as best you can and kind of the emotions go on the back burner. Dr. Tracy LeBeau is the other chief resident. With all the different things that we see, makes one very, very interesting. You never know what is going to happen. But a lot of those injuries can be extremely serious. So you have to really be on top of your game. Dr. LeBeau inserts a chest tube to drain the blood to the victim's chest. There's lost so much blood, the urgent
The blood pressure.
will either die. The trauma team must get sent up to surgery immediately.
You're on that too. All right, on to the next one, pericardial tamponade. So pericardial tamponade is kind of like a hemothorax, but it's in the heart. So the pericardial sac is the sac that encases the heart muscle. When you rupture an artery or vessel on the heart wall, the outside wall, it will bleed into there and it will crush the heart. Every time the heart beats, it gets a little more pressure. So it will crush the entire heart and it will kill them. It's fatal. The only thing that fixes this is a pericardiocentesis, which only a doctor can do. What they do is they go in blind with a large needle, puncture the pericardium and draw the blood out with a syringe. The only way to fix it. Now there's telltale signs and symptoms that you'll know in blunt chest trauma when it's a pericardial tamponade versus a tension pneumothorax. So the tension pneumothorax, the heart's being crushed also, correct? But you're also gonna have no breath sounds on one side. So you'll have tachycardia, hypotension, jugular vein distension, but you won't have clear and equal lung sounds. So the pericardial tamponade, you'll have clear and equal lung sounds and you'll have what's called a narrowing pulse pressure. So pulse pressure, pulse pressure is the distance between your systolic and your diastolic. So for instance, if you have a blood pressure of 120/80, your pulse pressure is 40. So the only thing that causes a narrowing pulse pressure is the pericardial tamponade. That number will continue to come together. And I have an example here. Well, actually, I have the video.
The heart is enclosed in a double-walled, fluid-filled sac called the pericardium. Cardiac tamponade happens when fluid accumulates abnormally in the pericardial sac to such an extent that it compresses the heart, leading to decreased cardiac output and circulatory shock. Tamponade may develop from a hemorrhage, such as from a traumatic injury to the chest, ventricular wall rupture after a heart attack, ruptured aortic aneurysm, or a complication after heart surgery. Fluid may also accumulate as a result of other health conditions, such as infections, autoimmune diseases, kidney failure, inflammatory diseases, and cancers. The rate at which fluid is building up is often more critical than the volume of fluid. Slow accumulation of a large volume may not cause tamponade, but a relatively small effusion can do so if it builds up too rapidly, because the pericardium cannot stretch quickly enough to accommodate it. Traumatic events usually lead to faster fluid accumulation and are therefore more dangerous. Cardiac tamponade symptoms are typical of a cardiogenic shock and include chest pain, rapid heart rates, shortness of breath, and in severe cases, dizziness, fainting, and altered mental status. The skin may feel cold, sweaty, and bluish. Neck veins may appear swollen. Diagnosis is based on clinical evaluation, typically the presence of Beck's triad, hypotension, muffled heart tones, and distended neck veins. Among imaging techniques, bedside echocardiography is the preferred method to visualize and determine the size of effusion. Tamponade is a medical emergency. Pericardiocentesis is usually the first procedure performed to remove excess fluid from the pericardial cavity.
The only way to go. There's an example of narrowing pulse pressure. So the first blood pressure you get is 90/50. What's their pulse pressure? 40, correct. Next blood pressure gets 82/46. What's their pulse pressure?
36.
Yep. Next one's 70/40. What's your pulse pressure?
30.
See how it's coming together? Then the last one, you get 52/38. They're about to die. Now what's their pulse pressure?
14.
Yeah, that's what a narrowing pulse pressure is. Pulse pressure number keeps dropping. You're gonna get that along jugular vein distension. The only treatment is pericardiocentesis. So you have to get them into an ER as fast as possible. Any questions? Oh, it took it away. Hard to find videos of pericardiocentesis. You gotta find it from a third world country that doesn't have MLS. All right, broken ribs. This is what usually causes your pneumothoraxes, but they don't always cause pneumothoraxes. All right, most of the time they don't, but they're very painful. You can stop your patient from taking deep breaths, and it can cause crepitus. Any questions? Flailed chest. You'll be hearing about this the rest of the semester. We have 3 consecutive ribs broken in 2 or more places, creating a free-floating island, so it causes paradoxical motion, or the sternum is completely separated from the rib cage. Want to see some videos of what it looks like?
Yes.
That usually helps if you can actually see it. This is what whale chests look like. See that? See how it goes in when the rest of the chest goes out? Goes the opposite direction. It's impossible to breathe adequately with a flail chest. See that one right on his sternum? Right by the left nipple there? Right above the right nipple there. That's a good one. Look at that one. Can't miss that one. You miss that one, you gotta go back to EMT class. Another good one. That's out in the field. Someone's taking pictures instead of giving this guy diesel. Hey, wait, don't transport yet. We gotta get video for EMT class. Was not me. You need to split that chest instead of taking pictures. There's a drawing of what a flail would look like. Patient with a skeleton. Any questions? So they do a flail chest. We tape from the sternum to the posterior ribs with bulky dressings placed over the flail. Gives the intercostal muscles thing to work on the exterior to create correct rise and fall of the chest. Any questions? No questions about flail chest? That brings us to traumatic asphyxia. I've never seen a case of traumatic asphyxia that survived. Is when you get sudden massive compressed to the chest, shoves all the blood in your head, your eyeballs pop out, your tongue pops out, your face turns purple, and you die. Any questions? Don't recommend trying it at home. So this one, motor cordis. I know I teach this well because there's actually a case of Komodo cordis, not last year, the year before last, on Monday Night Football, and I got 3 phone calls. I wasn't even watching the game. I was driving home from Sacramento. I got 3 phone calls in a row from former students. I just saw Komodo cordis on TV. So Komodo cordis is when, so remember how we talked about with the heartbeat, how the P wave is the signal, and then the QRS is the heartbeat, and then the T wave is the repolarization, so it can start over again. So if you hit it just right, blunt force trauma right on the chest, on the sternum, at just the right time during repolarization, that T wave, that'll send them into ventricular fibrillation, instant death.
I thought it was that, I thought there's no return for familial cordis.
Now you can get shocked with an AD and get it back. In fact, there's a really cool story. And I don't even like telling more stories, but I tell this one every day, every class. So back in the dark ages, we still were using chariots, rescue squads, and fire engines had to feed the horses hay. They invented this thing called an AED, automatic external defibrillator. Before that, only paramedics defibrillated people. They're outrageously expensive. This was in the 80s, and it would cost about $5,000 a piece, which in today's numbers would be about $40,000 a piece. So none of the volunteer fire departments here can afford it. So they applied for a grant from a place called the McConnell Foundation, which was a wealthy family from Wairika. And they applied for a grant to get 8 AEDs for the 8 busiest departments in the county. And McConnell Foundation denied the grant. We didn't get it. So everybody was pretty disappointed. Well, the day after, an anonymous donor came and cut a private check and bought 8 of the AEDs for Cincinnati County Fire Departments. Within less than, I think it was like 9 days after they got them trained on the rigs, a 16-year-old and a 12-year-old were sparring in their kitchen in Montague. And the 16-year-old hit the 12-year-old square in the sternum, gave him Komodo cordis and killed him. Parents started CPR, Montague Fire got there, put the AED on shock and got it back, the kid lived. So within 9 days, it paid for itself. Now, the real cool thing we found out later, which we just found out about 8 years ago, when she died, the anonymous donor was Mrs. McConnell, because she was furious with the foundation for denying the grant, so she cut a personal check, saved that kid's life. The kid would not have survived if they did that. Pretty cool. Here's an actual Komodo cordis. So The other important thing about this video is, and I know I've told you guys this before, but I'm gonna keep saying it, hopefully it'll get through your head. As an EMT, you're going to be doing event standbys. And on event standbys, it's real easy to get bored and wander around and not pay attention to the event, go talk to, oh, pretty girl. Get in line at the snack bar to get some food or a large Pepsi. That's not what you're there for. The reason why, if you're an EMT in an event standby, it's because there's potential for life-threatening injuries or situations. This is a case right here where this guy died, and they had EMTs standing by and they were screaming for him. Nobody knows where they're at, but they're supposed to be standing by at the event. Not good. Don't be that EMT. Yeah, it's still fatal. Medics. Still yelling for the medics.
What happened to the dude who punched him?
Nothing. It's an accident. It's blood cordis. What are the chances?
Yeah.
It's like with the guy in the NFL on Monday Night Football last year, 2 years ago. The guy that hit him in the sternum. I mean, who never guessed that was going to happen?
The ref looked at him, feel like he was faking it. He was like,
yeah, no, he died. It's not common. Blood cordis is not common at all. But it's very reversible if you get it shocked right back out. There's an AED right by it. All right, next one, pulmonary contusions. These are tricky devils. So pulmonary contusion is a bruised lung, or both lungs being bruised. If your lungs are bruised, they can't exchange gas, oxygen for carbon dioxide. If you can't exchange gas, you're a goner. So here's the deal. If I walk up right now to any one of this classroom and I smack them as hard as I can with this yardstick, are they going to develop an immediate bruise? No, it's going to hurt like hell. But it's going to be a couple hours before you get a nice purplish black mark on your skin as the blood starts to pool. Well, your lungs are no different. So when you get a major deceleration injury, remember that third collision, first collision is car hits something. Second collision is you hit something in the car. What's the third collision? Your organs hit the rib cage and your skeletal system. Well, your lungs, they hit your rib cage at 60, 70 miles an hour on that third collision. A few hours later, it's going to develop bruising. Now, where this happens the most in though, adults do get pulmonary conditions, but they're much more prevalent in pediatrics and children because they have soft ribs. Whereas in adults, you take hard blunt force trauma to the chest, the ribs break. And when the ribs break, it dispels the energy, right? It displaces the energy. With kids, their bones are still soft. They're not calcified yet. So that energy transfers through the ribs. They don't break. And the energy goes into the lungs. The lungs absorb all that. Then a few hours later, they develop into pulmonary contusions. So what happened is a kid will take a blunt force trauma to the chest. Chest x-rays will be negative because bruises don't show up on chest x-rays. And they look for broken bones. Everything's fine. Kid goes home, starts developing difficulty breathing, starts coughing up blood, decreasing O2 sats, and they're dead in a few hours. Very common thing. It's due to pulmonary contusions. Adults do also get it, especially with deceleration injuries. They're driving down the freeway at 80 miles an hour and rear end a truck or someone pulls out in front of them to hit it, that massive deceleration as the lungs slam into the rib cage. So, not even an MRI is not going to catch it. Monitoring O2 sats and signs and symptoms. Sometimes they'll moo them. Moo like a cow. the doctors will do sometimes. More observation overnight. They do a one night stay, they call it a move. EMS humor. So you hear the doctor talking about, now we're gonna probably have to absorb it overnight and start going. "Woo." Well, they can put them on a ventilator or CPAP, yeah, and start getting that Alexis, get the parts of the lung that aren't bruised, hopefully perfusing. Sometimes there's nothing you can do. Any questions? That brings us to cardiac contusions, which is the exact same thing as a pulmonary contusion, but it's your heart instead of your lungs. When your little heart smashes into the sternum at full speed and it gets bruised. So one of the only ways to tell that though is a person that doesn't normally have heart disease or an irregular pulse like a young person, they suddenly have an irregular heartbeat because the electrical synchronization doesn't work because of the bruised cardiac tissue. So you get a young person that's had one port strong to the chest and got an irregular heartbeat. Light bulb should be going on. Ooh, cardiac contusion. All these signs and symptoms are going to be on the next test, which is Thursday. So you better know your signs and symptoms for tension pneumothorax, hemothorax, open pneumothorax, cardiac tamponade, commotive cordis, pulmonary contusions, and myocardial contusions. There will be test questions on it. Say, what do you think is wrong? The most concerning thing about this patient? You got to know your signs and symptoms. Any questions? Last one we're going to go over, laceration of the great vessels. This is when you tear the aorta or one of the pulmonary arteries or veins to the vena cava. These people usually die in under 5 minutes. Sometimes though, if it's just leaking and oozing, they might last a little bit longer. Any questions? That's what they were fixing on that video we showed when they did the open thoracoscopy. And go in there and clamp the great vessel that was bleeding out. Any questions? All right, let's see what you guys have learned. You've been dispatched to the victim of a rock slide. What do you do first? Scene safety. You have BSI on the patient has been extricated from the rock slide to secure area, which is important because you don't want to get caught in the secondary slide, which is very likely to happen. Patient was working on a fence, we got caught in a rock slide. Number of patients is 1. You got plenty of resources, and you absolutely looks like you should be taking spinal mobilization. What's next?
General impression.
Correct. Primary assessment. General impression is a middle-aged male in severe distress. He's alert. He can't breathe. He's got no radial pulse. He's got large open wounds on his extremities that are not actively bleeding. What's that tell you? He's already in compensated shock. There's no blood to the extremities. He's got a weak, rapid carotid pulse. His airway is clear, but his breathing is not adequate. His respirations are elevated and shallow, and he's got asymmetrical chest movement. What is that? There's only one thing that causes asymmetrical chest movement.
Tension.
Right, a flailed chest. His skin signs are ashen, cold, and wet. Is this guy a priority?
Yes.
Why? I'm just kidding. What's next? History. Signs and symptoms, pain and deformity over lots of body systems. He has no known drug allergies, but he does take lisinopril for hypertension. He had lunch 3 hours ago. I was working on a fence when a rock slide hit. What comes next? Blood pressure 68 over 30, heart rate's 148, respirations at 28. Eyes are open. He's heard a person, place, time, and event. Follows simple commands. His abrasions and open wounds to his head. No JVD though, but he's got asymmetrical movement, but you've already splinted it. One tells you dimension bilateral, he's got a firm and distended abdomen. His pelvis is unstable bilaterally. His right femur is deformed and broken. His left fib is formed, broken. He's got left shoulder pain and left pinky pain and severe amputation. Second set of vitals is actually a little better than the first, but not good. And his Glasgow is 15 the entire time. Any questions? Yes.
So in this case, and again, like the distension of the abdomen, is that blood just like pooling in the abdomen
This
typically?
guy ruptured his spleen and fractured his liver.
So it's just all.
I'm talking about a broken pelvis and a flailed chest, and a femur fracture, and a tib fracture. And this guy completely survived this. Every one of these are real. Yeah, that is full of blood from a rupture, spleen and a fractured liver. No, the surgeon will go and clear all it out, and go in and repair the spleen and the liver. Cauterize and check. Does he meet trial criteria?
Yes.
Red or yellow?
Red.
Right.
Why is he red? Because it looks bad? Don't say yes. It's a pet peeve of mine.
And perfusion.
His respiratory rate's over 30, his blood pressure's under 80. He's got lots of.
Severe pain.
All right, any questions on chest trauma? Time for abdominal trauma. Abdominal and genitalia injuries. Ooh, there's some good pictures. Eviscerations. All right, thoughts for the day. The best people in the world are the ones who function highly in a true team setting. Treat every day and every patient the way you would want your loved ones treated. Never give anyone less than that. Any questions? All right, you got to know your hollow and your solid core organs inside your body. And what quadrant they're in. There's a list of your hollow organs. Any patient that has a family member that's a witch or is evil, the person to do is stand on their hollow organs. Protect. Any questions about hallowed organs? So, cool thing about hollow organs, actually hollow. Cool thing about hollow organs are, if they rupture, you generally won't bleed to death because they're hollow. There's no solid blood mass in them, so not like solid. The problem is most of them are for digestion, so they've got bacteria inside them. That's how you break down food. So that bacteria, when you rupture a hollow organ, ruptures and goes into your peritoneum. Peritoneum is the sac that holds all your guts in place. Then that's going to cause peritonitis, which is an infection of your peritoneum from all the bacteria. Any questions? All right, this brings us to the solid organs. Now you rupture one of these puppies, you'll bleed to death. So the liver is the biggest one. They got the spleen, the adrenal glands, the pancreas, and then the kidneys, which aren't even in the abdomen, they're actually in the retroperitoneal space because they're behind the peritoneum. So that's why they're the retroperitoneum. Any questions? Anybody has any questions about solid organs? Which quadrant there? You want to hear a tip? You rupture a spleen, you're gonna have left upper quadrant pain and left shoulder pain. It's a telltale sign of a ruptured spleen. Injured liver, it's gonna be abdominal pain with right shoulder pain. Telltale signs of those injuries. What's that? Right, it's their left and their right, not yours. Liver's in the upper right quadrant, correct. Takes up most of the upper right quadrant. Any questions about how the abdominal quadrant is divided? So we talk about injuries to the abdomen, we got closed injuries and open injuries. Closed injuries are when the skin is not broken. Open injuries are when the skin is broken. Any questions? All right, here's the signs and symptoms of abdominal injuries. Pain, pretty good indicator. Tachycardia, decreased blood, and all the signs of shock, plus a corner abdomen palpation and discoloration. Any questions? What does blood abdominal wounds do to your abdomen? Well, it causes severe bruising. That's the least they can do. Biggest things that'll kill you is a laceration of the liver or spleen that should bleed out quickly. Ruptures the intestine won't kill you quickly. Massive bacteria will go into your peritoneum. You can tear a mesenteric artery, which is the arteries that perfuse one of your organs. That would be very bad. Bleed out from that. Then you'll rupture, tearing kidneys. Rupture the bladder, you won't bleed to death, but you will get peritonitis, sepsis later because it's treated. Any questions? The other two are results of fractures of the solid or solid organs. No questions about blunt abdominal wounds. What do? We don't put them on backboards anymore. We protect their airway, monitor their vitals, give them oxygen, treat for shock, and give them some diesel. Any questions? We don't do the backboards anymore. Don't. Because there's no benefit to doing it. We used to put people on backwards because we thought it protected their spine, but it turns out it doesn't. I mean, if somebody has point tenders, those criteria I gave you guys, we'll put them on backboard for that, but not for abdominal. That's very old school. They can walk, right? I wouldn't make them walk. It's gonna bleed more if you do that. It's gonna increase their blood pressure. So a lot of your abdominal injuries and car wrecks come from improper seatbelt wearing. So your seatbelt should go across your pelvis. A lot of people put it across their belly and then they get in a car wreck. And it's really badly for them. It's like taking a razor strap at 80 miles an hour across your stomach. There's a great example of correct and incorrect positions in seatbelts. Yes. Yep. Left. It's in the left lower and the right lower quadrant. Both ways. But it's much outdone by the large intestine, which is in all four quadrants. It's all over the place. That look bad?
Yeah.
I mean, what that's from?
I don't think that's an injury though.
Which one?
7, 8.
3.
Yeah. That's
Yeah.
The latter too, right, in the eye?
I think so, yeah. So that's not real. But the next photo I'm gonna show you is real. And I'm showing it to you, because not only is it real, but also is a great example of lack of perfusion distal to an injury and what a demarcation line looks like on a live patient. You guys ready?
Oh my God.
So that guy crashed into a pier on a jet ski. And had one of the pier posts go through his inferior pelvis and out the back of his pelvis, lost his kidney, and completely shut off and compromised his left femoral artery. So you can see the demarcation line of where the artery is compromised. He's reasonably good color until, yeah, where the artery is compromised, they purple from there out. They were able to go in and revascularize that leg and save it. But that leg's only got a few hours till it's dead. I think he gave up jet skiing now.
What about everything?
So he had to have a complete pelvic reconstruction. Well, obliterated his pelvis.
How do you?
Huh? Don't know. Looking pretty close. Not looking good there.
How do you get that out?
Huh?
How do you get that out?
Carefully. Yeah, looks like it. Just put his pants on, cut around it. Yeah, he would have been a lot better off if he wasn't wearing pants. Any questions? So what do we do for penetrating injuries? We secure them in place. We never remove them unless they're blocking the airway. Any questions? Yeah.
One of the test questions said like, you remove it if they require CPR, so you could roll them over, like if it's in their
Yeah,
back.
only if it's blocking, start the ability to do CPR and they have no pulse.
Okay.
Then you have to.
Okay.
When you don't do CPR, they're dead anyway.
Yeah.
Want to see somebody get shot?
Yeah.
There's another unit that made the stop.
Good possibility, the guys from Boston.
On this perpetrator up here. Yeah, here we go. He's got the knife right here. Okay?
None of these guys are Irish.
Hey, drop the knife! Drop the knife! Just drop the knife, buddy. That's all you gotta do. Drop the knife. That's all you have to do. Drop the knife. No one's gonna get hurt.
Look at them. They all are.
We don't want to kill you, man. We don't want to kill you. Just drop the knife. Yeah, stop and talk. Stop and talk. What are you gonna walk into Boston? We want to get down to the. Hey, guy, you're holding up traffic here with. No, we're here to help you. That's all we're going to do. We don't want to kill you, man. Drop it. Drop the knife. Drop the knife. Drop the knife. Drop the knife. We don't want to do it. Drop the knife. Drop the knife. Drop it. Drop the knife. Drop it. Drop the knife. That's all you have to do. We're trying to work with you here. Yo, you lay down. You lay down. You lay down. Lay down, man. Lay down, brother. Lay down, brother. Lay down. Lay down. Lay down. Lay down. Lay down. We're asking you to lay down. Drop the knife and lay down. Lay down. That's all you gotta do, pal. Drop the knife. Do the right thing. Do the right thing. Do the right thing. Drop the knife. We'll help you out. We'll find out what the problem was, but you gotta do what we're asking you to do. Just drop the knife. Drop the knife. Just drop the knife. Drop the knife, pal. You're already. Drop the knife. What are you gonna do? You drop the knife and the gun go away. Okay? We're not gonna kill you. Why do we want to kill you? We don't want to kill you. We just want you to drop the knife. That's all you're gonna do. Drop it. Drop it, pal. Drop it.
What was that?
Come on, buddy, drop the knife. Drop the knife, pal. Drop it. Drop it. No, we don't want to do it, buddy. Just drop the knife, man. Drop the knife, buddy. Drop the knife, man. No, don't do that. Wait, hold on. Don't do it. Hold on. Drop the knife, buddy. Drop the knife, man. Drop it now. Drop it now. We'll give you a hand. We'll give you a. There you go, buddy. Drop the knife. Drop the knife. Get down, buddy. Get down.
I got this right here. I got this right here.
I don't think I hit him, but.
Watch this.
Pat him down and see if I shot him. I don't know.
Expose.
Did I shoot him?
We shot in the stomach.
Well, yeah. Oh, well. Too bad.
All right, now. What you guys worried about? What's that bullet hole?
Okay.
What? Did I say right upper quadrant? No, it's wrong.
Left lower.
Left upper quadrant, it's above his belly button.
Oh, I couldn't really see.
Spleen.
Try to stay away,
Like it was low.
Spleen, pancreas.
Continue to tell them to drop there. Once, at one point, Officer Holy tried to use the asp and take it away. He started running. He held the knife for himself. He was gonna stab himself. They got to the point where the state police officer tried to cut him off against the guardrail, and he ran Officer McCarthy, right? Jimmy, yes. And it was just a point where he just didn't want to, he was gonna end that way.
You feel okay?
I'm fine, perfectly fine, Chief. Officer McCarthy's fine. He did a great job, you know, did the right thing, protected himself.
Questions about penetrating abdominal injuries? Want to see the evisceration in real life? This dude had one knee before he got stabbed. Look at that. That's a full large intestine. I don't know what he ate. Yeah, big time shit. Lots of it. I don't know if he went to church and got him blessed first, but. Holy cow. It falls out. It's under pressure, so you rip open the. It comes out. So you guys put that back in, you just push it back in, right?
No.
No? What do you do?
Put it in a bag, right?
Yeah, well, sterile moist dressing. Wow, you guys learned something. You must have a great eating instructor. Yeah, no kidding. All right, any questions about eviscerations? That's a perfect world. Cover the moist sterile dressing, put aluminum foil over it, shiny side in, tape it all down. All right, kidney injuries. Just kidneying. That usually comes with blunt force trauma to the back, underneath the rib cage. Yes.
So the intestines are exposed. What if they're like cut?
Still do the same thing. Yep. Probably gonna need a bowel resection when they get into surgery. They just cut the two pieces off and sew them back together, throw that in the trash. Yeah. Oh, you got lots of intestine.
You have like person 6 foot, but they have like 6 feet.
I don't know, but it's a lot. So how do you know if someone's got an injured kidney? They're gonna have a hematoma in the flank region, they'll be peeing blood. Pain in the lower back, on the side, or on the flank. There's a good way to get a kidney injury. Any questions?
You said it was mostly back.
Yeah, because it's in the retroperitoneal space.
Okay.
Bladder injuries are pretty rare. You gotta break the anterior superior pelvis usually. Bladder's pretty well protected, but it can happen. You can rupture a bladder. That's bad news. The large intestines in all four. I thought it was in part of the upper left too. Because you're, yeah, next stomach, which should be left upper quadrant. Yeah, probably. Probably. I'll have to go look again. Let's go back and read. There's a good drawing of a bladder rupture. Usually, yeah, usually, like I said, it's for an anterior pelvic fracture, which is pretty rare. Male reproductive system. They can get injured. Had Lorena Bobbitt coming in for a guest speaker, but she couldn't make it. Don't know who Lorena Bobbitt is, can't help you.
For Dennis Rodman.
Dennis Rodman. All right, here's some injuries to the male genitalia. Some of these are for humor and some are not humorous at all. The Brits. All right, so that might have been funny. This one is not funny. This one's brutal. Oh. Oh. There it is in slow motion. I give up pole bolting after that. Here, watch it again while I check my phone.
It's pole vaulted.
Oh, yeah.
Any questions? So what do? Put the pieces of moist sterile dressings. That? What? Yeah, I mean, it's all in the lower quadrants. All right, female reproductive system's pretty well protected. Generally, it's intentional trauma or an assault to injure the female reproductive system. And we'll go over that in detail later on. Any questions? So we never pack inside a bleeding vagina. We put pads over the outside. Any questions? Be prepared to provide emotional support. Rectal bleeding is more common of a complaint than you can possibly imagine. And there's so much of it is actually from trauma. Some of it's from medical, from lower GI bleeds. And sometimes things get put in the rectum, it should never go in a rectum. That can cause bleeding.
Oh my God.
So again, we don't pack it, we just put pads over the buttocks and press it. Get them to a doctor. In a reported sexual assault, there's generally never a life-threatening injury at the area of the sexual assault. There's no reason to expose an example to genitalia. Just trying to keep them from washing, defecating, and urinating, and get them to what's called the SART facility, a sexual assault response team facility for proper collection of evidence. Any questions? Let's see what you guys have learned. Dispatch to a gunshot wound in the abdomen. What do we do first?
Yes,
PSI is on, scene to secure, victim injury. Patient was shot by his girlfriend. Number of patients, 1. You don't need additional resources. You're thinking about spinal mobilization, maybe. What is what comes after scene assessment?
Primary assessment.
Primary assessment. 30-year-old male, moderate stress. He's alert. Cheek complaints abdominal pain. He's got a radial pulse. His airway's clear. He's breathing adequately. No active bleeding. He's got ashen, cold, wet skin. Is he a priority? Yes. What's next?
History.
Pain in the abdomen. No known drug allergy. Takes lithium because he's schizophrenic. He had dinner an hour ago. Was in an argument with his girlfriend. She shot it. What's next?
Exposed.
Well, yeah, but what's next? Secondary assessment, which we will expose. He's got great vital signs. He's tachycardic. Moscow's 15. Everything's negative. He's got a firm and distended abdomen with a puncture wound to his right upper quadrant. It is now actively bleeding, so we're gonna put direct pressure on that. What is he pretty worried about?
Kidney.
No. Right upper quadrant. What's our biggest concern?
Liver.
Liver. So pack some onions in there and hope for the best. Any questions? All right. Let's go on to orthopedic. Yeah. That's what orthopedic injuries look like, closed and open. Bottom left-hand one, that knee's not supposed to go that way. So the bottom right, foot's supposed to point forward, not backwards. All right, be the best that you can be. You can never change what anyone thinks, does, or says. But you can be the best that you can be and hold yourself to the highest possible standards, regardless of what anybody else does. Any questions? Any questions? Oh, look at that skeletal system. Any questions on the skeletal system? No, it's not Karen Carpenter.
So
Sorry.
you have your radius, and your open,
Yes.
and you're gonna. Oh, I forgot the word.
Radius and the ulna.
Dude, it's, you're gonna apply a tourniquet. You would put it above, right? Because here it wouldn't make no, well, I'm.
You put the tourniquet at the highest spot possible.
Okay. I was-
And you put a second one just proximal to the wound.
Okay, yeah.
I double
I was
tourniquet.
just thinking, there's 2 bones and it's gonna be. No different.
Oh, yeah, well,
Oh, it will, but.
you put a tourniquet on, but yeah, no, you want to try to put it in the armpit or the groin.
Just, yeah.
Set it off upstream.
No.
All right, different types of musculoskeletal injuries. We have fractures, which is a broken bone. Dislocation, that's when the bone pops out of a joint. A sprain is when you damage the ligaments, and a strain is when you damage the tendons. Remember, ligaments connect bone to bone. It's tissue that connects bone to bone. And tendons are connect muscle to muscle or muscle to bone. I'm sure you know the difference between a ligament and a tendon, and a strain and a sprain. Oh, look at that third collision injury left there. Blows her hip right out. That's a dislocation. And then you got your skier twisting forwards, tip hip fracture. Then we got our mailman on the right. Any questions? Watch these guys. Don't do this at home. Watch his femur. Oh, see his femur? Oh. Ow. Yes, that first guy, he actually got a contract with Kellogg. That first guy got a contract with Kellogg's because his fever became snap, crackle, and pop all at the same time. Oh. So brutal. All right, back to his injury. He's brutal.
Gonna get picked up.
Holy shit! Oh, fuck, dude. He landed on his head, dude. He landed on his fucking head. I don't know. Oh, God.
Yeah.
Oh, Jesus.
Started my finger for doing this exact same thing.
What's that flashlight there?
You gotta go for it, dude. Do it.
Don't die.
Oh. I'll try this phone. So close. All right, so different type of fractures. We've got closed fractures. That's when it doesn't break the skin. We got open fractures when it breaks the skin. We got non-displaced fractures, which is what's cracking the bone. We got displaced fractures. That's when it's all deformed. Any questions? Then you get green stick fractures. That generally happens in children because their bones aren't calcified, so they just kind of splinter when they break. Yep.
Is there another word for that though? 'Cause
Not that I know of.
what is an
Epiphyseal fracture,
Yeah.
that's at the growth plate. Growth plates are usually right at the ends of the bones.
Okay. Can you go backwards one? In those.
Next time you see Connie, ask her to show your arm. She's got one short of the other because she had an epiphyseal fracture that affected the growth of that arm.
Oh. There's a question on the, please about that.
Yeah, the way I remembered it was I thought of seals, like, breaking children's arms. So I just say seals, the seal fracture. You're not gonna forget it now, are you?
No, I'm not.
Seals of a seal fracture.
That's different from the green, or is it same?
No, green stick's different. The green stick is just from the bone splinters.
Right.
But it's not at the growth plate.
Okay.
And there are, like, and a green stick fracture is not just uniquely for children, it just happens more often in children
Because their bones aren't calcified. I've never heard of a green stick fracture in an adult.
more
milk. Huh? Drink some more milk. Yeah, it's calcified. I got in trouble because I told the EMT class once that it was for people chaining themselves to trees. It's a fracture, but somebody didn't find it funny, so I can't tell that. No, I said I can't tell that one. I'm saying I didn't, because it's not funny. It's very serious. Any questions? All right, a common unit fracture. That's usually from arthritis, osteoporosis, or bone cancer. It's when the bone breaks into a bunch of pieces. It's like a three-dimensional jigsaw puzzle. Lots of fun for the orthopedic surgeons to put that together. Any questions on what a comminuted fracture is? Well, you wouldn't be able to sign the sentence, there's no way.
Okay.
It's not until you get a, but if you're taking a transfer, and the doctor tells you it's a comminuted fracture of, then you know it's broken into little pieces.
Is that the same as shattering a bone?
Yeah.
Okay.
Some people call it Humpty Dumpty syndrome, but that's not a medical term. Here's a good comminuted fracture with an almost complete amputation. This is actually an arm, I can believe that. Man. I really don't want to show us this.
شاور لي بس على اللي انت عايز تشاور عليه. قول يا باشا، قول اتكلم يا باشا.
This is the other layer. Enterobacter fractures or a craniotomy or a cranial landmark.
Said that was an arm, right? That was his elbow. Yeah. This one's got some pretty good ammunition, animation. How mechanism injury and comminuted fracture, pretty good. Yeah, maybe.
Orthopedic surgeon Terry Middleton examines Steve. His X-rays, he had a badly complicated fracture. At the height and the bone is broken into multiple pieces. Think of it as crumbs.
Now it's an actual video.
His throat smashed with a handlebar. Snapped in half. Raised with love. The impact shot through the brain. He was in his legs. Fracturing his left ankle. If you rate fractures on their severity from 0 to 10, with 10 being one that requires an amputation, Steve's fracture would be a solid 8.
A solid 8. All right, pathological fractures. I'm sorry, this one's actually usually caused by weakening of the bone from arthritis. Comminuted fracture can be from severe blunt force trauma, but it can also be from pathology. But pathological fractures is when you've got a tumor, arthritis, osteoporosis. Any questions about pathological fractures? Oh yeah, I've seen people roll over in bed and have pathological hip fractures. It just goes snap. There's the epicels. So if you look closely at the epicel fracture X-ray, you can actually see the seal. And off to the right, you can see his beach ball. Any questions? Epicels. So how do you know someone's got a fracture? Well, they could have deformity, they got tenderness, they're gonna guard it, they don't want anybody to touch it. Swelling and discoloration. That picture on the right is probably the fakest picture in me and people I've ever seen. They didn't even try. Any questions? Whoa. Those are pretty bad. So crepitus and false motion. So what's false motion? False motion, when you have no control over the extremity, it just dangles, just kind of free falls. I got a great video. Yeah. It's gnarly. Crepitus, when you hear and feel broken bones under the tissue. You ready? Oh, this is a good one. What could possibly go wrong?
Correct, Dustin.
I'm done. I'm so done.
Yeah, that's what,
Motorcycle accident and a broken leg. It's like. What street is this, dude? What street is it? Go find out. Look at the street. We need to find out what street this is. We have no idea. We're in the city of La Mirada or something.
you know, one city there, I don't know what street they're on. Be hard to get a 911 crews there. These guys were not prepared. So signs, symptoms of dislocation as opposed to a fracture, marked deformity, swelling, pain, all the same things. So you need an X-ray to find out. You're still gonna split, check this to see if it says before or after, because you don't know if it's a fracture or a dislocation. Exactly. Signs, symptoms of sprain, tenderness, swelling. The joints unstable because the tendons come off. Hey, look what we can do now. Any questions? Compartment syndrome. So compartment syndrome, you have a crush injury on an extremity, and then there's 4 fascia compartments. And if your cells start swelling and bleeding internally, they can actually crush themselves inside the compartment, kind of like an internal head injury. So you got to get them into a doctor that can do a fasciotomy as soon as possible. The video here is not the greatest video, but it does explain it pretty well.
Compartment syndrome is a condition in which increased pressure within a closed space compromises the circulation of the tissue contained within that space. This condition can affect any compartment in the body, but it most often involves the lower leg. Almost any injury can cause this syndrome, including injury resulting from vigorous exercise. However, the most common causes of compartment syndrome are fractures and soft tissue injuries. In this specific example, the tibia has suffered an oblique fracture from a traumatic force. Edema and hemorrhage cause fluid accumulation, elevating the compartmental pressure and occluding blood vessels and nerves. With clinical suspicion of acute compartment syndrome, intracompartmental pressure is measured. An absolute pressure of 30 millimeters mercury or higher, or within 30 millimeters mercury of the diastolic blood pressure, is considered diagnostic of acute compartment syndrome. Without urgent decompression, tissue ischemia, necrosis, and functional impairment will occur. Anatomy is crucial in the treatment of compartment syndrome. The 4 compartments of the leg include the anterior, the lateral, the superficial posterior, and the deep posterior compartments. Fasciotomy is the treatment of choice for compartment syndrome. Complete decompression of the lower leg is accomplished through a double incision 4-compartment fasciotomy. The first incision is placed halfway between the fibular shaft and the tibial crest. The fascia, anterior and posterior to the septum, is opened transversely. The anterior compartment is released first, followed by release of the lateral compartment. Care should be taken not to injure the superficial peroneal nerve located within the lateral compartment. The second incision is made medial to the previous incision, 2 centimeters posterior to the posterior tibial margin. Care should be taken not to injure the saphenous nerve and vein. The fascia, anterior and posterior to the septum, is opened transversely. The superficial posterior compartment is released first, followed by release of the deep posterior compartment. The double incision 4-compartment fasciotomy is now complete. Chronic exertional compartment syndrome is an exercise-induced condition different from acute compartment syndrome. In patients with chronic exertional compartment syndrome, The resting intracompartmental pressure is usually greater than 15 millimeters mercury. Pressure rises steeply after initiation of exercise, usually culminating in pain within 20 minutes. Burning, cramping, or aching pain and tightness develop, leading to cessation of activity. Intracompartmental pressure that remains over 30 millimeters mercury 1 minute after the end of exercise, or pressure that remains over 20 millimeters mercury for longer than 5 minutes after the end of exercise, is considered diagnostic of chronic exertional compartment syndrome. While initial treatment is conservative, a fasciotomy is the only proven successful treatment. Thank you for your interest in this preliminary exposition of our interactive program on compartment syndrome.
All right, any questions? Yes. Yeah. But you can't get it from like overexertion exercise though. Running marathons. Things like that. Serious injury, I've never seen these on the grading system on tests. But you never know they're gonna be there. So minor injuries are considered minor sprains or dislocations or fractures of your fingers and toes. Minor injuries is when you open fracture your fingers and toes. Non-displaced long bone fractures, non-displaced pelvic fractures, or any major sprains of a major joint. Any questions? Serious injuries are displaced long bones, multiple hand and feet fractures, because that's quality of life. Open long bone fractures, displaced pelvic fracture, which is life threatening. Dislocations of major joints, multiple digit amputations, laceration of major bloods, nerves or blood vessels. Kind of like what happened to Max in season 4 of Stranger Things. Yeah, it's the best show ever. Any questions? Put that video in there. Any questions on life threatening? I'd have put displaced pelvic fracture, life threatening, because it's threatening. Critical. You don't know if you're gonna live. Suspected pelvic fractures, imagine that. All right. That slide makes absolutely no sense. Disregard that. Of course, anytime you have a pulseless extremity, that's a trauma alert. That's red box trauma. Get them into a surgeon as soon as possible. Get that revascularized. Any questions? Ending with a loss of sensation. It's red box trauma. Any questions on assisting cuffing distal CSMs? No questions, huh? You should still get vital signs and a sample history regardless. What do we do? Splint in route. Check distal CSMs before and after. What's that? Any questions? Don't worry about hair saggers. Any questions about the Sager? So what happens if you don't splint properly? You can actually shut off blood flow. You can compress the nerves. They can lose distal CSMs. That's why we check distal CSMs before and after to make sure that we didn't screw up. Any questions? What do you do if you lose circulation or sensation after splinting? Yeah, readjust. Any questions on sling and flog? Look how realistic those photos are. Holy cow. Yeah, man. All right, air conditioning separation. This is with the heat exchanger and the fan. No, just kidding. It says and your AC joint pops out, your humerus is no longer in the joint. You can actually see it. That needs to be taken care of. If that doesn't get taken care of, they're gonna have a dropped shoulder the rest of their life. There's a lot of people with that. So they didn't bother to get it taken care of. There's a shoulder dislocation. That's a classic shoulder dislocation there. They guard it, they hold it. Lean forward. I've seen a snowboarder that's gonna come in looking like, Sling and swab. Fractures of the humerus are nothing to laugh about. Sling and swab. Not humerus. Well, it is the humerus, but it's not humerus. Any questions? Oh, that's a great elbow dislocation. Gotta watch out for pulling one of the arteries on that. Cause decreased circulation. Ooh, what's that? Anybody know what that's called? It's called an ouch. That's called a silver fork injury. See how it looks like a silver fork? Common in kids, they fall forward with their hand out. Snaps right at the distal ulna and radial. Looks just like a silver fork, but they can't eat with it. Any questions? No. I would generally use a SAM splint. Curl it up, hold it in position of comfort. College is a COS EMT class. How can I help you? It's okay. Uh-huh. 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 Okay, shouldn't do that. Anyway. Okay. Yeah, where's your alternator shift on the amps? Like what numbers? There should be numbers. That's not bad. So 12. All right, when you're done with this, call one, have us walk you through, check the cables. All righty, okay, back. All righty. That's the saddest one. That right there is exactly how I would treat a silver fork fracture. Any questions? What? Then you know, I mean, so you still use it. I mean, that's a natural position, so you just put it there like that and just split it like that. Pelvic fractures. If it's an open book, you can use a pelvic stabilizer if it's in your state scope of practice. In California, it will not be. Open book, it's got to be open. Not an open book, there's no reason to stabilize the pelvis.
Pelvic fracture overview. Anatomy, you find here the SI joint, the ischium, pubic bone, symphysis pubis, ilium, sacrum, and the strong sacroiliac ligament. The sacroiliac joint have posterior ligaments that is very strong, and the stability of the pelvis depends on the integrity of the posterior weight-bearing sacroiliac joint complex and transfer of the weight from the spine to the lower extremity occur through that joint. Pelvis is a ring. When the force occurs, it will injure the ring in the front and the back. The anterior injury and the posterior injury. The anterior injury is usually obvious, will be noted on radiograph, and usually associated with the posterior injury or a fracture. The posterior injury could be occult. Always look at the back of the pelvis. Unstable pelvis will have a gap or comminution. The posterior fracture is serious. We need significant blood transfusion, we need surgery, and the outcome will be unpredictable. That posterior fracture is a serious injury that will lead to instability of the pelvis and a lot of bleeding. This bony instability, if it is not corrected surgically, it can cause late deformity, limb length discrepancy, and pain. Types of pelvic fractures. There are 3 types: anteroposterior type, lateral compression type, and the bad vertical shear type. The first type is the anteroposterior compression type. You can have that with pubic rami fracture, as you can see here in the slide, or you can have it as an open book type. When the symphysis pubis opens up, we call it symphysis pubis diastasis. Treatment: close the book, pelvic binder or a sling, surgery if the symphysis pubis diastasis is more than 2.5 centimeter. The surgery can be done through an external flexor or a plate.
Let's say you guys are planning to do pelvic surgeries. So mask pants, believe it or not, are in the national registry scope of practice. This is not legal in California. These are pneumatic anti-shock garments, or also known as military anti-shock trousers. They may be on the test list as either one of those things, but they're the exact same thing. They can be listed as PASG, which is pneumatic anti-shock garment, or MAS, which is military anti-shock trousers. Depending on who made them, that's what they're called. What these things do is they work great for stabilizing pelvic fractures. It's got 3 air bladders, 1 for each leg and 1 for the pelvis and abdomen. They're designed by the military in Vietnam to create a false shock, so that people that were bleeding to death have caused increased systemic vascular resistance and actually increased their blood pressure and kept them alive until they got them to surgery. Unfortunately, like all tools in EMS, they were used inappropriately by very bad EMTs and very bad paramedics. So we kept the very bad EMTs and very bad paramedics and got rid of the tools. Any questions? All right. Huh? Not California. Lots of states use them, not California. Yeah, and paramedics don't use them either. The California, we have very, very strong union states, so we protect incompetence and we get rid of the tools, so they can't hurt anybody with the tools. That's what we do. Don't want to lose employees.
So military anti-shock trousers
Or pneumatic anti-shock garment, they're the same thing. Just depends on who made them, what they call them. Kind of like a cougar, a mountain lion, and a puma. All the same thing. For a deer and a deer. Same thing. All right, dislocation of the hip, that's when the femur pops out of the pelvis. Not comfortable. Any questions? Oh yeah, people can come out of the pelvis.
One question.
Yeah.
So the ligaments and tendon tears, like how common is that if we dealing with a fracture in general? Like
Not generally a fracture, because a fracture displaces all the energy.
okay.
So ligaments and tendons don't tear. I have heard of injuries though, like severe trauma injuries,
Yeah.
where it's ripped out the ligaments and the tendons, like especially on knee, like you know, in football, I've
Right.
seen that, but it's pretty, it's not common.
So like and even with the hip dislocation too, like that It's likely not.
Usually that puppy just pops out.
Okay.
And you can actually, their physicians sometimes can actually just pop it right back in right there in the air. I actually watched, they call it a reduction. I actually watched a friend once that dislocated his shoulder playing softball. It was in the championship, so they actually reduced the shoulder. His buddies did it right there on the field, and he kept playing.
Did they win?
No,
It was pointless.
they're getting a little too old. So hip fractures, the hip fracture is actually a proximal femur fracture. It's when you break the proximal femur and the head of the femur is still in the pelvis, but the rest of the femur is just loose, floating around in your leg, tearing up soft tissue. No, it's horrible is when you have a hip fracture, someone takes a pelvic binder and binds it and tears all the soft tissue and arteries together. That's terrible. That's why we don't have pelvic binders, because we had to get rid of the pelvic binder to protect them. Any questions? Fractures of the proximal femur. So the old wives' tale used to be if you had rotation outwards and extension, it was a fracture. And if it was rotation inward and shortening, it was a dislocation. But they found out that scientifically, there's really doesn't do that. That was just somebody made that up somewhere and put it in the book, and everybody kind of like, oh, okay. That's why you see the top picture there. It's not actually a real thing. All right. Here's a great femur fracture. That was a horrible idea.
Yeah, that's a little big.
Any questions? Any questions on how to break your knee?
Superman?
How common is it in just like a crash in general, like a front end collision to have the knees?
If they're not restrained in the front seat, fairly common.
But
A lot of people wear seatbelts now, though, so that doesn't happen a lot anymore.
But I just figured these are close to the
Yeah.
knees and everything.
Well, it depends on the car too, the vehicle. Yeah, some people, the knees were right there on the dashboard. There's a double kneecap dislocation. Look how comfortable that looks.
I did that one, well, not both, but
Oh,
just one of them.
oh. COS EMT class. Not yet. All right, go to break. Come back in 5 minutes after 8. There, another on break. Yeah. Okay. Okay. See. Collect it off, so I'll have Dave check it. All righty. All righty. Sir, just grab it quickly. Okay.